Assalamu alaikum. Good morning, everybody, ladies and gentlemen. We are honored and privileged to kick off the 20th AAU Congress in collaboration with the 16th KUA Annual Conference here in the lovely city of Kuwait with the lovely weather. We have the privilege of seeing different urologists from different parts of the Arab world and even Arabs beyond borders. So this is a great pleasure to have in Kuwait, and we hope for a successful meeting, and we hope you enjoy staying in Kuwait with us. So for the first session, we will welcome the moderators, Dr. Yasser Farahat, Dr. Dlaim Al-Hajri, and Dr. Ghassan Talahma, if he's here, and we will start our first session. Please, Dr. Yasser.
Thank you, Dr. Hussein. Good morning, everyone. Actually, it's a great honor and privilege to be back again with the Arab Association Annual Conference, to be in Kuwait for the second time. I think after 10 years ago, we were here in Kuwait, and I really appreciate the effort that has been done by the Kuwait Urological Association, Dr. Dulaim, Dr. Hussein, all the team, Dr. Mustafa. It was really a great effort through a full year of activity, and I really appreciate the organizer for preparing such wonderful venue and all logistics for this conference. It's really a great honor to have the AAU conference here in conjunction with the Kuwait Urological Association. Well, without further delay, let's start with our session. The first session will be about urolithiasis. And we have our first speaker, Dr. Swami. He's a consultant urologist from Pet Urology and Kidney Hospital, Hyderabad, India. And he will talk about updates on thulium fiber laser lithotripsy.
Chairpersons, my dear friends, colleagues, a warm greeting from Hyderabad, India. So let me begin with the conflicts. There are no conflicts of interest here. So why do we have this talk here is because the laser lithotripsy has been the standard of treatment for renal stone management, and holmium IAG laser has been the gold standard until now. But in recent years, we have seen a new laser coming up, that is the thulium fiber laser, which has gained popularity. And the clinical studies have been started in 2018 and FDA approval in 2019, and the EC remarks has been obtained in 2020. The holmium laser for the past decade has been the most satisfying most of the properties of the laser. But why there is a lag? Because what we need more from this laser is it has to form a most finest dust. The large stone we can faster ablation. Let's have a fewer complications. We want to work into the lower pole and fragment the stone without any basketing or getting the best result in the lower pole stones. And smaller laser fiber, improved irrigation will help in the better vision and definitely a less retropulsion. Thulium fiber laser has these qualities has been met by this laser. Let us dig a little bit deep into it and understand the updates on it. So as you all know, just touching the basics, holmium and thulium fiber laser. Holmium has been the flash lamp method with which it gives out the laser energy. Whereas in thulium fiber laser, we have a diode through which a silica doped ion fiber is transmitting the laser here. So basically what major difference between the holmium and thulium fiber laser are? So wavelength. So wavelength, you can see the thulium fiber laser is almost less than the holmium, which has a better water absorbability. The peak energy that can be produced in thulium fiber laser is least, that is 0.025 joules, which is not seen in a holmium laser. The maximum energy is both on both the sides. The pulse duration is also the least and the maximum, that is 12 milliseconds, which is not available in the holmium laser. So pulse shape, it is a pulsed pumping probe, whereas it is electronically modulated pulse. The maximum frequency that can be reached in a holmium laser, the highest energy laser is around 120 hertz, whereas we can go up to 2000 hertz, which is hardly required in a clinical practice. So when we compare this laser with all other lasers which were available and which were there in previously, So you can make out that the absorption coefficient in water is highest with the thulium fiber laser. So this is one good property of this laser where it is absorbed into the water which are present inside the stone, which helps in making the bubbles faster and breaking the stones better. So laser beam profile is also very precise compared to the holmium. This gives a pinpoint, small, very well maintained laser fiber energy there, because of which it is a better energy efficiency. Holmium ag laser is 1%. I would say TFL is around 12% better energy efficient. So what we need the energy is very less for the thulium fiber laser, which can run on two machines. You can run on a hair dryer machine, but it is not possible with the holmium laser there. Easy installation, yes. Holmium laser, you can just plug in into a normal working output in your day-to-day life, which is not been possible with the holmium laser. So main two differences with the thulium and holmium ag are the pulse energy, which is 10 times faster, lower, the frequency, which is 25 times more, and the peak power is 4 times less. That is around 500 watts is the maximum energy which can produce by the thulium fiber laser. So these are the energy what we use with the thulium fiber laser in our day-to-day life for the dusting, the fragmentation and popcorning. So pulse width, now the latest machines have been upgraded with adjustment of the pulse width. You can use a short or a long pulse width there. So these are the soft tissue applications. It has a wonderful soft tissue applications also. Let us see some clinical applications here. So you can make out the faster popcorning and the fine dusting, which is possible with the thulium fiber laser compared to the holmium. So energy what we have used is around 0.2 joules and 150 hertz. It gives the finest powder in the thulium fiber laser, which is not possible with the holmium. Even if you use the highest energy and frequency, you will have little bit of fragments which are difficult to get dissolved. So popcorn powder. So this is a quality of powder what we get. So you can see on the right hand popcorn with 0.2 joules and 150 hertz. The quality of the powder is very fine, almost like a fine dust, which is not seen with the holmium laser. In URSL also we can use a thulium fiber laser. Many have the concerns of the heat destroying the ureter and the strictures, but let me tell you, we have been using this thulium fiber laser for the past 3 years in my hospital, in my own setup, where not even a single stricture has been reported until yet. And it is not the problem of the laser, it is the way you use the laser that makes the difference with these complications. In PCNL also it works wonder. In PCNL we don't dust the stones. If you have a larger access sheet, you fragment it and evacuate the fragments easily. You don't have to, fine dusting is not required here. So works well. You can use highest energy, that is up to 2 joules. It breaks the stone very fast there. In ultra mini perk also, these are have a very minute dust can be done when you have a difficulty, vision is poor. You can just lace the stone, completely powder it and evacuate the powder on spot without have to getting into any trouble there. So even if you touch the mucosa, there will be a little bit of blanching. Nothing will happen. Take it for granted. Very, very minimal side effects onto the ureteral walls there. The TFL has the property of the tissue application, which gives an excellent dissection. It's almost like a knife or a Swiss cheese. When you cut, it will be so smooth cutting onto the tissue level. Energy requirement is also very less. 1 joule and 10 hertz works very well. We have been using this for our en bloc tumor resections and the prostate, the bladder neck resection. It has shown a very good result. So hemostasis, I should say, is excellent. We have yet to see a patient going back into the theater for clot evacuation. The latest trend, what we have to upgrade onto this thulium fiber laser, new terminologies, that is the ablation efficiency, that is the total energy used against the volume of the stone, and the ablation speed, that is the volume, total volume of the stone which was laced by the active lasing time. So these two are the latest which define the quality of the laser working efficiency. So ablation efficiency, TFL laser is needed to ablate 1 cubic millimeter of stone volume regardless of the stone density. It requires a very less energy to disintegrate the stone, which is not true with the holmium laser. When the two settings are equally matched, that is same laser fiber and equal settings are used, ablation volumes are up to 2-fold or 4-fold higher depending upon the density of the stone. If a soft stone, it is 4 times better. If it is a hard stone, it is twice better compared to the holmium laser. As the ablation rate is also better, the ablation speed of TFL is faster than the one seen with the holmium mag laser in this setting. Even when compared with the very high energy machines with up to 120 watts or 80 hertz, TFL still scores better, about 1.5 to 3 times in faster fragmentation and dusting modes irrespectively. So overall, the fragmentation is twice compared to the holmium laser. Dust is faster, finer, and ablation speed efficiency translates into less operating time. And dust and residual produced or dust quality is very fine. Residual fragments significantly smaller than the holmium laser. So I have to tell you, I have been using the holmium laser for the past 4 years before I was using the holmium fiber laser. Alternate day after weekly once, we should have kept a patient for a relook after doing a procedure to confirm whether the fragments are gone or not. Take it for granted, after having using the thulium fiber laser, the time, the requirement, everything has come down, and the relook we hardly do any relooks now, because we know that such kind of fine powder dust, everything gets washed out. We have done multiple times relook to confirm it, then only we were able to confidently say, yes, this works better. So retropulsion is least with the thulium fiber laser. Holmium has around 3 times with short pulse and a long pulse. And retropulsion visibility, retropulsion sometimes even absent in this thulium fiber laser. Clinically significant retropulsion at 1 joule is seen, and optimal visibility is up to 95%. Visibility decreases with very high frequency. I have to say this because once the frequency is more, definitely the vision will be hampered. You have to use it intermittently. So there is laser fiber resistance to fracture is also very less. So even a small laser fiber that is around 150 micron is now used, and in future we may get up to 50 micron also, which will definitely increase a better visibility. Irrigation is improved, you will be able to get the results much faster. So compared with the smallest fibers, digital flexible scope smaller with the laser fiber smaller, I think it will change the world. So various composition also, it has the same result. There is no difference between the fragmentation power with the thulium fiber laser there. So fiber burn back is seen in thulium fiber laser only when you have a very high energy, that is up to 30 watts. It is very less. Once you cross it up to 50 watts, if you are using, then the fiber burn back increases. So what are the more problems that has been faced commonly are the carbonization and the temperature effects. Let me tell you, the high power laser has a disadvantage. So heat production and thermal effect are not evaluated clinically until now. Whatever the guidelines we have, whatever the studies have been done, are in vitro studies. So let us use it with caution. The temperature rise and the power used, the temperature, even with holmium laser, the temperature rises to 70 degrees Celsius if you use at a 40 watts power. So same thing happens with the thulium fiber laser, where the temperature increases up to 33 degrees Celsius when you are using the frequency of 150 to 300. But once you cross more than that, that is around 500 hertz, then the temperature increase happens. But these are all in vitro studies. We don't know whether this will clinically replicate the same thing in the clinic, in vivo, whereas very hardly or very rarely we use a 500 hertz. It is unnecessarily. So temperature concerns, only if you use less than 500 hertz, it is safe, but still clinical studies are required. So can it be, it is a safe anatomical location. Any anatomical location you can use, can be an endoscopic approach, smaller residual fragments, better visibility, and no temperature difference between the thulium and holmium mag laser when you're using at a low power energy with a good irrigation. So thermally it is safe. So these are the charring what we see commonly. There are few sparks and few charring when we use very high energy and we are very close to the stone, and hardly it will any matter anything to the patient per se or the instrument per se. So these charging are the high power laser which will give that sparks, but they get absorbed into the water and hardly any difference to the patient. Better avoid such charring by using a less energy and less frequency. Most important is an impacted stone. where the thermal energy is going to damage your ureter if you're not using it properly. So should be impacted zone. You should be more careful to get it dislodged, or if it is not possible, use the lowest energy, lowest frequency to be on a safer side. So at the last, thulium fiber laser here it's going to stay here. As you know, with the great power comes great responsibility. We need to know how to use it properly to get the best result out of it. Thank you.
Thank you, Dr. Sawami. We will gonna make the question at the end of the session. Our next speaker will be Dr. Ahmed Al-Nahas. We're gonna talk about the shockwave in the era of endourology. Dr. Ahmed is professor of urology and nephrology center, Mansour University, Egypt. He has 119 international articles and publisher and 5 books chapters, and he is editorial board of the Arab Journal of Urology. Dr. Ahmed.
Good morning. Thank you, Dr. Duleim. Thank you, Dr. Yasser Farhat. I would like to thank the organizing committee of the Arab Association of Urology Conference and the Kuwait Urology Association. ESWL in the era of endourology. We will talk about comparison of shockwave with flexible ureteroscopy and percutaneous nephrolithotomy, how to improve the shockwave results, the guidelines, and the take-home messages. After introduction of shockwave lithotripsy for treatment of urolithiasis 40 years ago, it was thought that it will be suitable for every type and every size of the stones. But with technological development and refinement of the techniques, the endourologic treatment options have become more common, leading to the decline in the use of shockwave lithotripsy. This study compared percutaneous nephrolithotomy versus shockwave lithotripsy for 20 to 30 millimeter single renal pelvis stone. Shockwave had significant lower stone-free rate, 75 for shockwave and 95 for percutaneous nephrolithotomy, and it have significant lower, percutaneous nephrolithotomy have significant lower retreatment rate, 5% versus 75%, and complication were more with percutaneous, 14 versus 7%. This study compared the flexible ureteroscopy versus shockwave lithotripsy for treatment of lower poly stones of 10 to 20 millimeters. Flexible ureteroscopy provided significantly higher stone-free rate, 87 versus 68, and lower retreatment rate, 8 versus 60 when compared to shockwave. Again, complications of flexible were more than shockwaves, 13 versus 5%. Shockwave lithotripsy versus semi-rigid ureteroscopy for proximal ureteric stones less than 20 millimeter. Shockwave and ureteroscopy had comparable stone-free rate, 84 versus 88. Ureteroscopy had lower retreatment rate, 2.3 versus 65. And complications were more with ureteroscopy. What are the benefits and harms of ureteroscopy compared to shockwave lithotripsy in the treatment of upper ureteric stones? In this meta-analysis and systematic review, ureteroscopy was associated with significantly more stone-free rate up to 4 weeks, but the difference was not significant at 3 months. And ureteroscopy was associated with fewer retreatment and the need for secondary procedures, but with greater complications and longer hospital stay. Comparison between the treatment modalities for renal calculi 100 to 300 square millimeter. Single treatment success was better for percutaneous nephrolithotomy, 95%, 88% for ureteroscopy, and 60% for ISWL, which is significant. When allowing the 2 sessions of shockwave lithotripsy, the success improved to 79%. And auxiliary treatment were more common after shockwave. So the bottom line is, any endourologic technique had more stone-free rate, lower retreatment rate, and less need for auxiliary procedures. On the other hand, shockwave lithotripsy had the lower complication and shorter hospital stay. So shockwave is safer because it is non-invasive. but the results are not predictable. What's the next step? Should we stop doing shockwave and go directly to flexible ureteroscopy and PCNL, or we improve the results of shockwave? This is a prospective multivariate analysis of factors predicting stone disintegration by shockwave to know the risk factors and go away from them. Avoid shockwave lithotripsy for patients with predisposing factors of failure, like large stones, more than 20 millimeter in the kidney, more than 10 millimeter in the lower calyx or in the ureter. Avoid shockwave lithotripsy for hard stones, more than 1,000 Hounsfield unit in non-contrast CT. And avoid shockwave lithotripsy in obese patients, skin to stone distance more than 10 millimeter or body mass index more than 30. The second method to improve shockwave results is to avoid shockwave for patients with risk factors of complications, like uncorrected coagulation disorders and uncontrolled hypertension. How to optimize shockwave in the 21st century? To increase the efficacy, you have to use a slow rate, 60 to 90 shocks per minute, adequate coupling and targeting of the stone, voltage escalation, which is called the power ramping, and using the lowest energy that causes stone disintegration. In the last European guidelines, when the stone is 10 to 20 millimeter, shockwave and endourology are at the same level. For the lower pool stones, if the anatomy is favorable, shockwave lithotripsy and endourology are equivalent. These are the unfavorable anatomical factors for the lower pool stone. If the angle between the infundibulum and pelvis is less than 90 degrees, if the neck of the calyx is narrow, less than 5 millimeter, or the neck of the calyx is long, more than 3 centimeters. For the ureteric stones, when the stone is in the proximal ureter, less than 10 millimeter, shockwave and ureteroscopy are the same level. In the distal ureter, less than 10 millimeter, shockwave and ureteroscopy are the same level. So the current indications, shockwave lithotripsy is indicated for non-lower pole renal stones less than 20 millimeter and lower pole renal stones less than 10 millimeter, provided there is favorable anatomical factors, and ureteral stones less than 10 millimeter. This diagram shows the frequency of doing shockwave, ureteroscopy, and PCNL in urology and nephrology center in Mansoura. As you see, shockwave has the upper hand all the years. The take-home messages: shockwave is still playing a role in the treatment of upper tract calculi because it is the only non-invasive treatment. Proper selection of patient is the key to have good results. You have to choose the indication and go away from the risk factors of complications and failure. Practicing efficient techniques increase the stone-free rate and decrease the complications. For every patient, the decision of the best treatment must be a balance between the goals of treatment, which is the stone-free rate, and the efforts required to reach these goals. Shockwave is a technology that will be utilized for treatment of urolithiasis till the development of another, more effective, non-invasive modality. Thank you.
Thank you, Dr. Ahmed. It's really interesting presentation, but I think it opens a lot of questions and discussion. We'll keep it at the end of the session. We'll move forward to the next speaker, my best friend here in Kuwait, Dr. Hussein Al-Anezi. He will talk about choosing the best calyx of PCNL puncture. Actually, Dr. Hussein, his profile is very long and will take a lot of time of his presentation, but he is I think he's known to everyone. He is graduated from Medical School of University College of Dublin, Republic of Ireland in 2004, after completing his residency training in urology with the honor degree in 2013. He is a consultant urology here in Kuwait, and we are happy to listen to his lecture about choosing the best calyx PCN.
Thank you so much, Yasser, for the great introduction. We're happy to have you here, always in Kuwait, and to have the Arab urologist and the international urologist as well. And indeed, you're a very close friend, so thank you. So, what is the definition of the perfect puncture? For endourologists, we know that the straightest, the shortest puncture that can get you to get a complete clearance of the stone with a rigid nephroscope and avoids complication. That is probably the definition of the perfect puncture in BCNL. But is it always possible? I don't think that is always possible. Sometimes we have to take a compromise. We have to use flexible scopes, we have to use combined endoscopic procedures, and we have to sometimes to do multiple punctures in order to render such patient as stone-free. So how to achieve the best, not the perfect, let's say the best puncture in BCNL? I think we have to take in mind so many factors. So first are the general factors that apply to every patient, and then factors that apply to different patients at different strategies. So we have to take in mind the preoperative imaging and planning and the intraoperative and planning for each patient and decide what is the best for that particular patient. And as we know that we are now moving towards a patient-specific approach, so every patient is treated differently. So for the anatomical consideration, we all know that the kidney is very well perfused, and we can see this network of arteries compassing and covering most of the renal parenchyma. But as we know from our anatomy that the posterior aspect of the kidney is less perfused, or it has less branches, and there is the avascular Brodels line. So if we take this close-up picture of the calyx, probably going through this direction into the calyx to puncture the calyx will actually render avascular access, while going through here or here might actually injure some of the vessels surrounding the calyx and causing bleeding. So this, as we said, in the blue line is probably the best approach for puncturing the calyx, which is a papillary axis. This is just to show you an example of how a little deviation from the cup of the calyx, if we go there and then we have this bleeding and during the procedure, and this led actually to the formation of pseudoaneurysm and future angioembolization for that patient. So a little deviation might actually injure the vessels surrounding the calyx, and that might need further procedures for treating the bleeding. Other anatomical consideration is the pelvic-calcaneal system. Look at this. We have different pelvic-calcaneal system to mainly every patient. So every patient is different. We have patients with long infundibula, patients with short infundibula, patients with dilated calyces, patients with bifid systems. Every patient is different. So we have to treat every patient as per his data and anatomy. Other general consideration is when we are actually aiming for a high axis. So if we're doing a supra 12 rib puncture, we have to know that it's mostly safe and the rate of thoracic complication is low. However, this might be our favorable axis in cases like UBJ stone or stricture, and upper ureteric stone, and anomalies like Harshaw kidney, and sometimes in Harshaw kidneys or Harshaw stones, as we will see. Other general considerations, if we go supra 11th, then this is a very risky axis, and we have to know that this is probably transpleural and transthoracic, so there is a risk of thoracic complications very high, and the risk of liver or spleen injury is very high, especially if we go lateral on that particular patient. So I think if we're planning to go supra 11th, we have to use either ultrasound or CT guidance to prevent complications such as the thoracic and adjacent organ injuries. Retrorenal colon is particularly common in lower pole axes and thin patients, in females, in the left kidneys with the previous bowel surgery, and patients with anomalies like horseshoe kidneys. So in preoperative imaging, I think everybody gets a CT scan, and the CT KUB give us a very wide information that we have to use. Usually I see the relation of the kidney to the ribs, where actually the 12th rib and the 11th rib lie in relation to the kidney. I see the stone burden from the CT scan and the distribution of the stones. Sometimes you might get a clue about the pelvic calcium system, and that's good. But in recurrent cases or in complex cases, you might need to get a CT urography with contrast in order to delineate the anatomy in a better way. We can get further information from the CT KUB, and that's the renal parenchyma that we're going to traverse with our needle, actually the angle of your axis, and if there's any adjacent organs, like we can see here in the yellow arrow, the nearby colon. So all of those information can actually be got from the CT KUB. When you get a CT KUB, please look at different images. So we can get the axial, the coronal, and actually the sagittal. The sagittal is very important. As we can see, this patient with an upper ureteric stone who was treated with a BCNL, if we actually get this axis through the upper pole, it's going to be non-papillary and it's supra 12, so this might be risky for bleeding. And if we go supra 11, then this might actually go through the spleen. But if we can go through the lower pole, this might be actually safe, but we might have to use flexible scope. So see how much information we can get only from preoperative imaging. Again, this is another case with a Staghorn stone. Usually with the Staghorn stones, the long axis of the stone might give us a clue about the best calyx to puncture. So in this particular patient, probably going through the upper calyx only from seeing the KUB will actually render most of the stones cleared by a single puncture. And if we look at the same patient, if we look at the CT scan, this was the case. So if we look at this yellow arrow, this axis through the upper calyx is actually pleural or subcostal, so it's not going to be injuring any thoracic structures. And also, if we look at the sagittal views of the CT scan, we can see that most of the stone can actually be cleared with the rigid nephroscope. The only concern was actually highlighted by the red circles, where there is like a middle calyx and lateral stones, and this might actually need flexible ureteroscopy either from up or down, or sometimes it might need another puncture. And this was the case in this patient. Actually, this patient was cleared only by a single puncture, upper pole, with the use of flexible scopes and intraoperative. So again, intraoperative planning. If we put the patient on the table, what we have to consider? I always, because I do prone BCNL, I always aim for a posterior calyx. I think it's because in this particular position, it's the straightest calyx to get into, and we're not traversing much of the renal parenchyma if we put a needle into the posterior calyx, where if we put a needle into the anterior calyx, you're actually going very deep into the parenchyma in order to reach that anterior calyx. Consider the stone location and longitudinal axis of the infundibula. You have to target a dilated calyx if possible for better access to the stone and to actually get your wire a good length of the wire inside the kidney before dilating. You have to target the calyx with the largest stone burden in order to clear that stone as much as possible before prodding your procedure to the rest of the kidney. And I think if more punctures are needed, then put the wires initially. But with the help of flexible scopes and with combined intrarenal surgery, you might not need that anymore. What about the sheath size? if you have different sheath sizes, then I think the size of the infundibulum will actually dictate what sheath size you are using. So if we can see here the different sizes of the standard amplatz sheath, the mini BCNL and the ultra mini BCNL, this will actually correlate to what is the size of the infundibulum. And if you use a larger size sheath to a narrow infundibulum, this will cause actually bleeding and might cause infundibular stenosis in the future. So please, according to the size of the infundibulum, use the proper size of the sheath. This is a case of intra-operative planning. We always do retrograde pyelography if possible, and this delineates the pelvic calcium system, and we should always correlate this to a preoperative imaging. So if we look in this particular patient, this lower axis was actually straight with the stone and was cleared by the rigid nephroscope. However, if you do an upper pole axis, then this actually might be difficult to reach the stone, and you're going to need a flexible nephroscope in order to treat the stone, which is difficult a little bit. And this will also be a supra 11th puncture, which will increase the risk of complications. What about this middle calyx? This is still supra 12. It's overlying the ribs, and the infundibulum is not that wide, so it will not help you. So probably the best access, and this was accessed by the lower pole calyx. One of the tools that will actually help you, and I think Dr. Fadl will give us more information about this, is the intraoperative ultrasound usage. I think it's very beneficial if you're unable to ossify the pelvic calcium system. It's beneficial to give a safety margin from adjacent organs for a safe puncture. It might be offhand with anomalous or ectopic kidneys in cases with musculoskeletal deformities. And we have to know that ultrasound-guided puncture is very helpful to reduce radiation for both the patient and the surgeon. So this is one case where I found ultrasound very helpful. You don't always have to use the ultrasound in only puncture, but as we said, you might get more information before you do your puncture. So this is a 7-year-old boy who was planned for mini PERC, and he had 2 stones, one in the renal pelvis and one in the lower pole. And we can see from the CT scan there was a nearby colon. So we were afraid from that colon preoperative. Intraoperative, we did our pyelogram, and when we see that this is a bifid system going through the upper calyx was supra 11th. We might have to use a flexible and difficult to reach because of the angles, as we can see. Again, from the middle calyx, it's supra 12, which is okay, but the rib is nearby, and we have to use the flexible in most of the case. But if we go through the lower pole axis, that is a direct to the lower pole stone, and then we can get from the other pictures, as we can see, a straight access to the renal pelvis stone with the rigid instrument. So what we decided is to do an ultrasound and to mark where's the safety margin for the bowel. As we can see in the images from the ultrasound, bowel was seen, and we had a safety margin mark on the patient. And then the access was done actually with the retrograde pyelography, and this patient was rendered stone-free. So you can use multiple tools to actually achieve that safe access for the patient and decrease the risk of complications. One more tool is, I think it's a great tool, but you need 2 expert hands and those situations where you can get retrograde endoscopic guidance, or what is called combined intrarenal surgery. It's good because it has a visual confirmation of puncture site. It may reduce the radiation exposure to both patients and surgeons. ECRs may reduce the number of punctures required and increase probably the stone-free rate, but it comes at increased cost, increased time maybe, and the need for additional experts' hands, as we said. So for the take-home messages, perfect puncture may not always be possible, so always get the best puncture possible, and the priority is to always reduce complications and achieve as much as possible stone-free rate. Puncture planning starts pre-operatively. and you have to get as much information as necessary before starting your procedure. Careful interpretation of preoperative and intraoperative details for the best calyx to be punctured is of paramount importance, and the use of all tools possible to achieve a safe access, because getting a good access, I think, is the most important step in every PCNL patient. Thank you very much for your attention.
Thank you, Dr. Hussein. We will leave the question at the end. Our next speaker is Dr. Fadl Hamouchi, and he is Assistant Professor of Urology at McGill University in Montreal. His practice is focused on ultrasound application in endourology and prostate inoculation. Dr. Fadl, he get his medical education from University of Sherbrooke, from Quebec, and residency program from McGill University. He's interested in population health and is currently enrolled in MPH program at the Bloomberg School of Public Health at Johns Hopkins University. Dr. Fadl, welcome. First time in Kuwait, and hopefully you enjoy your stay.
Thank you very, very much. I'm indeed very pleased to be in Kuwait. صباح الخير للجميع. شكرا على الدعوة اللطيفة. So today I'm going to be talking about something that's very close to my heart, which is ultrasound PCNL, how to teach it, how to learn it, and what's the learning. I'm not going to tell you guys what you already know. PCNL is first-line treatment for stones more than 2 centimeters. This is recommended in American guidelines, European guidelines, and multiple international guidelines. What I do want to talk to you about is a little bit of history. And I would love to start with this article that was published by Steve Nikada, who is at University of Wisconsin, and who is currently head of the American Urology Association, where he goes over the history of PCNL. Now, this paper was published in 2015, and they go over all the timeline that led to the development of the PCNL that we know today. How did it start, and how did it evolve? The first percutaneous nephrolytotomy through a percutaneous tract was actually done in 1976. Since that time, there was a lot of development, and for those of you who know this picture, these are 4 of the surgeons who are considered to be the fathers, in a way, of endourology. And Dr. Segura, who's the gentleman on the left side, who did his practice in Mayo Clinic in Rochester, he writes in his memory the following. He says, "It was the widespread availability of fluoroscopy that was the key to the popularity that percutaneous nephrostomy tube placement enjoys today. I believe that had there existed something like an endourology table, we and Nat Radiology would be putting these tubes in today." So when we talk about PCNL, the relationship, the historical relationship between fluoroscopy, X-ray, and PCNL is the reason why we do PCNL the way how we do it, simply because it was developed this way. And this led to multiple percutaneous access techniques: bullseye technique, triangulation, simplified 090. However, one of the main limitations of PCNL and percutaneous access is the very steep learning curve. We know that the competence, or to achieve competence in X-ray PCNL, you require 60 to 65 cases, and this has been proven in multiple large studies. And even for excellence, you need up to more than 100 cases. So despite it being the most popular technique used today, we know that the learning curve is quite steep with X-ray PCNL. But I'm not here to talk about X-ray PCNL. I think Dr. Hussein did a fantastic job. I'm here to talk about ultrasound-guided PCNL. Now, despite ultrasound-guided PCNL gaining a lot of popularity in the last maybe 10 or 15 years, in fact, it's not new. It has been there since the 1980s. This paper was published by Dr. Noll from Germany in 2005. And in 2005, he already describes his experience with more than 300 cases of ultrasound-guided PCNL. And the results were quite phenomenal. 97% stone-free rate, low complication rate, no transfusion required, and no injuries to the neighboring organs. Now, despite that, ultrasound did not necessarily pick up in popularity. In 2018, Dr. Traxer and group did a contemporary review to assess the use of ultrasound in PCNL. They reviewed all the literature comparing ultrasound and X-ray, and what they found was quite significant. So compared to fluoroscopy, ultrasound had a similar safety profile, a similar complication rate, a significant reduction in radiation, all the way up to 0 radiation with full ultrasound PCNL. Ultrasound-guided access is associated with decreased bleeding, decreased need for transfusion, slightly higher stone-free rate compared to fluoro, similar hospital stay, and reduction in cost. So it is clear that ultrasound-guided PCNL is a great alternative modality for fluoroscopy. It is radiation-free, it offers real-time imaging, it is less cumbersome, and it definitely costs less. But is it teachable? And is it easy to learn? So let me walk you through this, this paper, which is assessing the learning curve of Thomas Chi, my mentor at the University of California, San Francisco, and my good friend, where he describes his own learning curve with ultrasound-guided PCNL. And to do that, he looked at his first 100 cases using ultrasound to gain access. And then he divided these 100 cases into 5 groups of 20. The endpoints that he looked at were fluoroscopy time, radiation exposure, and success rate. Now, naturally, the more comfortable he got towards the 100 case, he used less fluoro. So you can see that the fluoro time reduced significantly, and the exposure and the radiation exposure reduced significantly as well. More importantly, though, is when you look at the actual learning curve and the success rate. You can see that after 20 cases, there was a significant deflection in the curve, and there was a significant improvement in his success rate, leading up to 100% success rate at the end of the learning curve. Now, but someone may make the argument that this is an experienced endourologist. What about ultrasound naive, like trainees or residents? Well, we did a study at the University of California, San Francisco, where we actually looked at the resident learning curve for ultrasound-guided PCNL. We had 10 R4 residents, 10 PGY4 residents with basic exposure to ultrasound, and we monitored their consecutive success with ultrasound PCNL. Our main endpoint was the success of the access and the time it took to actually get the access. And then eventually we were able to create a learning curve model. So a total of 48 ultrasound access were attempted. The total success rate was 73%, which is quite significant for PGY4 residents. But more importantly, if you look at the graph, you can see that already after 4 consecutive cases, there's already an improvement in the success rate. And at the 7th case, the success rate is 90%. Same thing, if you look at the time, you can see that after 4 cases, the time required for access is less and less. So then ultrasound is teachable, ultrasound is transferable, but how do you learn it? If someone never did ultrasound, where do you start from? Well, I believe that if you want to learn ultrasound-guided access, you need to break it down, you need to dissect it into 4 main competencies. The first one, obviously, is to get comfortable with imaging. The second one is to identify your needle during puncture. The third one is to know how to move your needle. And lastly, is to practice targeting. And I'm going to try to go over these 4 steps one by one. So step number 1, imaging. The goal is to become familiar with the terminology, with the image acquisition, and to develop a protocol for evaluating kidney the same way every single time. Probably a very good place to start is the machine itself. You need to understand how the machine operates, because if you don't know how to operate the machine, you're going to have some difficulty actually doing your procedure. But we as clinicians, we're not necessarily trained on that. So we don't necessarily know what's clinically relevant. And for that, I'm currently writing a paper with some colleagues from McMaster University as an introductory to basic knowledge of ultrasound. What we, urologists, need to know to better improve our usage of the ultrasound machine. Step number 2, you need to know the basic motion of the ultrasound and how does each motion change your actual image. And that's very, very relevant. Number 3, you need to understand how to frame your image. So if you look like, for instance, on the left side, that's a very deep image. So yes, you're seeing the kidney, but that's not the best image that you want. When you're learning ultrasound, you need to know, or you need to learn how to get the best image every single time. Usually when we start, we always start in a horizontal way, parallel to the floor, to see the kidney. But you need to remember that the kidney lays in a diagonal way. So when you want to think from an interventional urologist perspective, you need to ultrasound parallel to the rib to be able to be oriented in the same orientation with the kidney. Get comfortable with the normal anatomy. How does a normal kidney look like? What are the normal findings in a kidney? But also get comfortable with the common findings. How does a simple renal cyst look like? A kidney stone, like the post-acoustic shadow, twinkle artifact, renal mass, angiomyolipoma, parapelvic cyst, etc. It's important to know the structures where you want to put a needle in, but also the structures where you should not put a needle in. So pleura, for instance, is something that we can see on ultrasound. what we call the sliding S sign, which is a sign that you can see there. And technically, it shows you where the pleura comes in and out of your field during inspiration and expiration. Bowel. Bowel is very important because there's a lot of air in the bowel. It tends to have a bright, echogenic, spiculated appearance. And it's usually at the inferior margin of the kidney, like you can see there. So it's very important to get comfortable identifying these structures before starting doing ultrasound-guided access. Perinephric fluid is also relevant, especially when you start doing procedures. Small tips and tricks, if you want to learn ultrasound, the first thing I would recommend, get a portable device and put it in your clinic. You want to try to ultrasound as many patients as possible and try to correlate CT findings with ultrasound findings to be able to be more and more comfortable. Collaborate with your local radiologist. Be a good friend with your local radiologist, and even spend some time with the radiology technician in your hospital, because there's a lot to learn from these people who do this procedure every single day. Step number 2, needle recognition. So there's multiple ways of puncturing a kidney, whether you want to puncture a kidney or anything else. There's the longitudinal puncture, where the needle goes lateral to the probe, and there's the transverse puncture, when the needle goes in the middle of the probe. Now, if you're starting to learn, probably the easiest way to do is to do the longitudinal puncture, simply because it's easier to recognize the needle as it goes in from the skin all the way down to the calyx of interest. So don't waste your time trying to see it in a transverse fashion. It's more complicated, especially if you're starting. Start with a longitudinal puncture. And to do so, just invest in a very cheap phantom model, get an ultrasound device, and get a needle. And the goal here is simply to see the needle. We're not talking about targeting. You just want to see your needle. And to do that, you want to try to practice on and change the orientation of the probe, and each time change the way how you puncture, until you get comfortable seeing the needle every single time. Step number 3 is needle movement. Now that you see your needle, now that you know that your needle is exactly where you want it to be, you want to move it to the right and left of the screen, and you do that by getting it towards the probe and away from the probe. Keep doing this until you're absolutely very comfortable with the procedure. Lastly, targeting. So now it's time to get the needle where you want it to be. There's multiple phantom models that actually exist. This is one I like and we use in our training centers. It has multiple targets, and it allows you to confirm whether or not you managed to get your needle exactly where you want it to be. Now that you're comfortable with imaging, you recognize your needle, you know how to target, it's time to take it all to the operating room. And you can always have X-ray as a backup, but once you have solid knowledge in these 4 steps, it's time for you to go to the operating room and to attempt ultrasound-guided PCNL. So to conclude, ultrasound is a safe and efficient alternative to X-ray PCNL. It has definitely more advantages. It's teachable, it's transferable. To learn it, you need to break it down in multiple steps and take it one step at a time, and practice is definitely key. I'm going to finish with this paper that was published by my friend David Zoe at the University of Arizona, and I hope that every one of us is asking himself the same question today: why are we still performing exclusively fluoroscopic access? On that, I'm going to thank you for the opportunity. Thank you very much.
Thank you, Father. Actually, we'll around to close this session with an interesting continuous debate, continuous controversy about 1.5 centimeter stone in the lower calyx. How to do it, either PCNL or mini PCNL or flexible arthroscopy. We'll start with our eminent faculty, Dr. Wissam Kamal from Saudi Arabia. He is known to everyone. He is working at King Fahd Hospital, Jeddah, Saudi Arabia, and he is the resident training program director and head of Saudi Endourology and the minimally invasive group. Welcome, Wissam, and hopefully you can convince all of us to go for mini Berg. See how difficult to go for PCNL, even to start the presentation. So till he get his presentation in the room, majority are preferring flexible or mini Berg. Welcome, Wissam. Go.
Okay, good morning, everybody. First of all, I'd like to thank the organizing committee, Dr. Hassan Al-Anizi and Dr. Delaim, and also I'd like to salute Dr. Yasser Farhat for his efforts in the Arab Urology Association for this collaboration between the Arab colleagues. Thank you very much. So, as Dr. Hassan Al-Anizi said, there's no perfect. Maybe there is best, and maybe there's worst. So let's go and see what's the best or the worst from these 2 scenarios. So to judge what's a good endourological outcome, we have to look for the stone-free rate, operative time, complication rate, hospital stay, and post-operative pain. So it's a matter of efficiency and safety. As Dr. Yasser Farhat mentioned, everybody loves ureteroscopy. Why? It's a natural orifice. It's a day surgery procedure. It's less technically challenging than PCNL. But we have to remember that the ureteric anatomy is not that simple. It has many kinks, it has many curves, and even with the DG stent, it's not a straight tube. And when I think about the lower pole stones precisely, I think about this picture. You have these advances in flexible ureteroscopy where you can reach actually the lower pole stone, but when you see, especially when you see a large stone, what you can do after that. So as we mentioned earlier, the efficiency is the higher stone-free rate, lower operative time, cost effectiveness in terms of instrument and hospital stay. This is a very important paper and an interesting paper. Said we have to look at the stone with the volume. So when you have a stone that is a 15 millimeter, in order to fragment it, you have to go up and down the ureter 53 times with the ureteral axis rate of 13 to 15 to remove fragments of 4 millimeter stones. Imagine going all that time with the ureter, along the ureter. So for that, the term dusting became very popular and trendy between urologists. But what's actually dust? And this study by Traxler et al. Showed in order to identify the fragments as dust, you have to have dust which is smaller than 250 micron, which is actually smaller than the laser fiber. So a 4 millimeter, a 3 millimeter, a 2 millimeter stones or fragments are not considered dust. So Dr. Swami gave a beautiful presentation about the TFL. Now with the new lasers in the market, with the Moses technology, the TFL, the high power laser and the Thuliumiac, everybody's going towards the flexible ureteroscopy. And as he mentioned, one of the advances that the companies advertise the fiber laser is having the frequency of 2000 hertz. But who can work with 2000 hertz? Do we really need it? And Professor Olivier Traxler is one of the main advocates for flexible ureteroscopy and the biggest advocates for TFL. But even though he's proposing that, you have to be careful because, as we mentioned, that frequency times joules equals watts. And when you fragment stones, there is an energy translated into heat. So he recommends that you don't exceed 25 watts in the kidney. So one of solutions for this heat energy is the irrigation. This is a study showed that when you increase the irrigation, the heat energy decreases, and smaller volumes receive greater thermal dose and reach a threshold of tissue injury more rapidly than larger volumes. But what happens when you increase the irrigation? This is a picture of one of my patients. He had a lower pole stone. Even though we use an access sheet and the procedure is less than 1 hour, you can see the difference between the shape of the kidney on the left side and the right side. The kidney is really swollen. And this is another patient where we did the simultaneous bilateral endoscopic surgery, which is ureteroscopy on one side and PCNL on the other side. So guess which one is the side of the PCNL? Surprisingly, this is the side of the flexible ureteroscopy. He has a prerenal hematoma and fat stranding. And this is another case referred to by my colleague. This patient refused PCNL, not the physician himself. So he got stone-free rate with the TFL, as they said. But look what happened after the procedure. He had severe left flank pain, and this hemorrhagic cyst appeared because of the intrarenal pressure. So, and this study showed that when you increase the irrigation, the rate of the irrigation fluid absorption increases, and also decreases the barotrauma. So what are the risks for pressure and backflow? Fluid overload, bacteremia and sepsis, barotrauma, collecting system rupture, renal hemorrhage, and increased pain. All of this can happen just because that you increase the irrigation. And this study showed that one of the main predictors of getting infection or sepsis after ureteroscopy is the procedure time. And I believe this is one of the most important studies recently published. It's published just this year, 2023, that they reviewed 110,000 patients undergoing ureteroscopy. The rate of sepsis post-ureteroscopy is astonishing. 5.6% of the patient had sepsis. And one other factor that is interesting, that during the study period between 2015 and 2019, the prevalence of sepsis increased from 4.7 to 6.6. And this might be because we are pushing the edge and treating more stones with the flexible ureteroscopy, more and more stones. So one of the solutions for increasing the intrarenal pressure is the urethral access sheet. We all know that the urethral access sheet might keep the intrarenal pressure below the dangerous standards, but we know that with the urethral access sheet we have these problems like ureteric strictures, mucosal injuries, and so forth. And this is another study showed that strictures develop post-ureteroscopy in 2.9% of the patient. In patients who develop strictures after ureteroscopy, 35% required drainage, 21 required endoscopic intervention, and 4.8 required reconstructive surgery, and actually around 2% underwent nephrectomy. And this is one patient in our hospital. She had a horseshoe kidney and this stone. The patient didn't want to go to PCNL, so she had 3 sessions of flexible ureteroscopy. She's stone-free, but unfortunately she developed this long stricture in the ureter and underwent reconstructive surgery afterwards. So for the mini PCNL, many studies compared the mini PCNL with the ureteroscopy. Most of the study, you can see with the bold here, most of the study, the stone-free rate was highest. Most of the studies were in comparison with the ureteroscopy. The operative time was the lowest. Even the complication rate was comparable between the 2 groups. Of course, the hospital stay in the mini PCNL is longer. Regarding the cost for endoscopes and disposable materials are significantly lower in the mini PCNL group. And even for the analgesic requirement, you may assume that mini PCNL requires more analgesia, but actually they are the same or comparable in 2 groups. The intrarenal pressure, this is a study showed that the flexible ureteroscopy had the highest intrarenal pressure, regardless of instrumentation and irrigant pressure during all the procedure. Of course, my colleague will talk about this bendable access sheet with the suction. This might push the limits for using more of the flexible ureteroscopy, especially with the new advances. But I prefer to use this section with the mini PCNL. Why? It has a better irrigation capabilities, so I don't need to worry about the heat irrigation, and it has the space that the irrigation could come out, shorter sheet, and better and easier section and separation of dust and fragments. And studies show that actually with using mini PCNL with the section, you not only increase the stone-free rate, but you keep the intrarenal pressure at lower values. We have many lasers, as we mentioned previously. You can use the laser in flexible ureteroscopy, but you can use it also with the mini PCNL, and you can use a trilogy. Many of these technologies are beautiful when you use it with the mini PCNL. And this is again, we show the Tholium-YAG. You can do dusting and fragmenting and aspiration of the fragments with the vacuum effect and the active aspiration. What I like about mini PCNL, this is a patient with a lower pulse tone, exactly 1.5, but the Hounsfield is 1/300. So when you do mini PCNL, you respect the anatomy of the kidney, with as you see in the RGP. We put a ureteric catheter, the incision is less than 1 centimeter. You put the ureteric catheter with the fullest catheter, and you remove it the next day, and the patient goes home without the degestant and 100% stone-free rate. So as my friend Dr. Hassan mentioned, it's all about personalized stone approach. You have to look at all of these factors before you decide which is better. Is it flexible ureteroscopy or PCNL? And I like to share this case recently. She has a 2 centimeter renal pelvic stone. So exactly 2 centimeter, and that was, on both sides. I told her, okay, we can go either with flexible ureteroscopy or mini PCNL. And she said, look, I'm coming from another city. I have 5 children. I need to be stone-free rate at the lowest time that you have. So that's what we did mini PCNL, and the patient was 100% stone-free rate and was discharged on the next day. In conclusion, no study shows the superiority or even the inferiority of ureteroscopy compared to PCNL in terms of stone-free rate, intrarenal pressure, or temperature rise. the high-power holmium and TFL have the potential to cause thermal injuries, prolonged RIRS procedure risk, pilovenous return. One of the serious complications of ureteroscopy is ureteric strictures. The use of ureteral accessate might increase this risk. And thank you very much.
Thank you, Dr. Wissam. Our next speaker will be Dr. Rahid Joshi, talking about the management of 1.5 centimeter lower power stone, how I do it, mini PCNL, flexible ureteroscopy. Dr. Rahid is an alumnus of Institute of Kidney Disease and Research Center, a joint secretary of Ahmedabad Urological Association, and joint secretary of and treasurer of Gynecology Association. He has under a member of ultrasound guideline committee on BPH and a mentor for ultrasound accredited fellowship in Endourology at Arna Super Specialty Hospital. He has experienced more than 5,000 laser endourological procedure and through a class of didactic hands-on training course. He has mentored more than 50 urologists in advanced endourological procedures. Dr. Rahid, thanks for joining us.
Yeah, till the time the technical glitch gets over, let me congratulate Wissam for a fantastic presentation. And I think he made my job very easy. 80% of the time which was allotted to him, he spoke about flexible URS. So this is about lower polar stone, which is 1.5 centimeter. Let's be very focused. I have some disclosures. I have been on panel of Boston Scientific and Teleplex. So there is no conflicts of interest. I believe science prevails over commerce. Now, whenever as surgeon we ask that what is an ideal surgical procedure, if we remember the Hippocratic Oath which we took, we have to have three aspects: safety, efficacy, and sustainability. And as a urologist, when we look for an ideal stone procedure, what we need is some procedure which gives us maximum stone-free rate with minimum morbidity and which has got a long-term prospect, which is sustainable and which is reproducible by urologists at large. The main concern here, what Wissam also highlighted, was the morbidity. But nothing ideal remains in this world. The world keeps on changing, and I think we are all clinical scientists, so we also keep ourselves evolving. We invent, then we come across some limitation, we improvise, we innovate. So this quest for an ideal procedure which will keep on evolving. So till that point of time, I have three options for my patient who is having 1.5 centimeter lower polar stone. We all know that: shockwave, mini PCNL, and FURS. Now, let us not go to my personal opinion or Wissam's opinion or any case studies. Let's go to the guidelines. This is an EUA guideline, which was recently in a couple of talks back somebody highlighted, and it shows EUA guideline that for a 10 to 20 millimeter stone, there is an option of shockwave lithotripsy, FURS, PCNL. It was a diplomatic statement from EUA, but the AUA was more blunt about it. And the guideline statement they showed that, we cannot offer lithotripsy. So for us, today, the debate remains only between the flexible URS and mini PCNL. Now, again, go back to the guideline, and this is actually in favoring Wissam, that all these highlighted things shows that for a stone which is between 10 to 20 millimeter, mini PCNL gives better stone-free rate. Whenever we choose flexible URS, it is our duty to have a shared decision with our patient and inform that we cannot access the stone. We might end up with a two-stage, and we can have failure of laser fiber and ureteroscopic damage. So these are the concerns why this guideline still doesn't favor flexible URS as the primary modality for our patient. And if we dissect all the cases, all the studies which they took into consideration, we can see that mini PCNL scored over flexible URS only in two aspects: stone-free rates and the ancillary procedure requirements. But if you look at the rest, all aspects, the pain, analgesic requirements, urinary leakage, blood transfusion, hospitalization, return to the normal activity, quality of recovery, every aspect, the RRS fared far better. And this, my friends, is an era where we have to look for the quality of life, not the stone-free rate. So my personal choice for an 1.5 centimeter stone would be flexible URS. And I think there are a few concerns in everyone's mind here, and if I address those concerns at the end of next 5 to 7 minutes, all of you will join me to select 1.5 centimeter stone FURS. I promise that. So what are the concerns all of you have? First, inability to access the stone, which Sam rightly told. There is a risk of laser fiber failure. There is a risk of damaging your ureteroscope, cost implications to you, inferior stone-free rate and requirement of second or third stage. And lastly, longer operative time and all this septic complication which he highlighted. Let's address it one by one. See, if there is a non-accommodated ureter, you are not able to pass the sheath or the scope. But my friend, we started with 9 French scope, then came 8.4, then came 7.5, and within next 2 months, we are going to get 6.4 French. And to the right of your skin, that is 6.4 French sheen scope, which can just walk. Even your rigid, semi-rigid URS, which is 6.5, you can easily accommodate that in any ureter. So that is out of the question. Secondly, this is, unfriendly PC system. If there is too much of angulation, now look at the flexibility which we are getting with this 7.5 French sheen scope. Now it can access any lower pole. But somebody will tell, Wissam will tell that, this is the flexibility you are getting only when there is no fiber inside. My friend, this is on the left is the flexibility without the fiber, and now we have 150 micron fiber. So on the right side, even with 150 micron fiber, the flexibility range is as good as without the fiber. So with the TFL, now we are getting even 50 micron fibers. Imagine what flexibility we will have and what calyx we will not be able to access. Next thing is risk of laser fiber. When you are having laser fiber, you will not be able to reach to the zone. Now here you see, this is an 11 o'clock. Now we have 2 different scopes. One is 11 o'clock access, one is 2 o'clock access. So on the left side, now that particular stone which is not been accessible by the 11 o'clock, we can very well reach there with the help of 2 o'clock scope. Now here, we can easily go with the 2 o'clock entry of laser fiber, and we can reach right up to the calyceal end. So now things are changing. We are getting different scopes. So that can make things easy. Now question comes, which is, bothering all of you, the damage to flexiscope. If you keep on working in the lower pole, it is going to get wear and tear damage, and your flexible scope will go in 10 to 20 cases. This was a concern when there were no digital single-use disposable ureteroscopes. But now we have these digital scopes which are single-use, and now, my friend, the scope which was available at 80,000 rupees, in soon, near future, is going to come down to 25,000 rupees. And if that scope works for 5 cases, I don't think cost has any issue. With the 50 micron, again, the damage is very, very less. Now coming to a very relevant aspect for the patient's perspective, the inferior stone free rate. Yes, I agree. The literature says the overall stone free rates with the flexible URS is 74 to 89% as compared to 93 to 95% in mini PCNL. And lower pole has even worse stone free rates. But this is again thing of past. Why? Because there are so many game changers now been introduced, Yasir. These are the game changers: correct imaging, digital scopes, TFL introduction, and the suction. Let's see the correct imaging. Now, gone are the days that we use sonography and ultras and X-ray KOB. We have to use NCCT KOB with bone window. If you use universal imaging, then there will be universal reporting of the residual fragments. And the definition, as he rightly said, less than 250 microns. So anything which is more than 2 millimeter is considered as clinically significant. And if you stick to that, now we see with the availability of digital flexiscope, look at the vision. This was the vision in the conventional scope, and now this is the vision in the digital flexiscope. If you get this kind of vision, I think your performance of the flexible ureteroscopy will be far better. You'll be able to pick up smallest fragment and dust it. So this makes our life so much easy, and we can give far better result. Coming to the game changers, laser, holmium laser, though it was 100 watt, 120 watt with Moses, it never gave us proper dust. But now it has been thing of past. Now what we have is TFL laser, which has got excellent dusting efficiency. And there are n number of reports. It says that it can produce twice as much as stone dust. It can produce 1/4 of the dust particle size, which is even less than 2 millimeter. And the ablation efficiency is 1.7 times faster. So with availability of TFL, again, the stone free rates are getting encouraged. And last thing, which hit the nail in the coffin of mini PCNL was suction. If you are doing suction from above, why can't I do suction from below? And if I can do suction from below, why would I puncture someone's kidney? No, I won't do that. So there are 3 types of suctions. Now the commonest and the most clinically relevant here is either through a bendable flexible sheath or using direct in-scope suction. Now look at this. Now this is the first kind of podigi for the bendable section. See, there's got a V-limb. From this V-limb, we could introduce the suction, and we can collect all this dust into a stone basket. And this is the suction which is happening through ureteral access sheath. Now we can very well see that all of the fragments are getting easily sucked out, and they are getting collected into the boss without any problem. If I can do this much of effective suction, if I'm getting this much of dust from below without puncturing the kidney, would you puncture? I won't advise. Last thing was direct in-scope suction. Now, this is the one thing which is coming in a big way. This is the prototype which has been right now studied in a literature, and we are very soon to come out with the reports, and we are getting it patented. And this has got fantastic kind of, suction ability to suck the dust under vision. But mind well, this can happen only when you use TFL with an excellent dusting efficiency. If you use holmium, those fragments, if you try to suck it from the scope, it is going to damage your scope. So you need to have this. And with this kind of direct in-suction efficiency, I don't see there is any problem with the stone-free rate. My friend, this is the dust which we get out of this. And this is the landmark study. This is going on. We are going, very soon it's going to get published. 45 patients across 4 countries, 4 surgeons. All the Guy's stone scores were, involved in this particular study. CT scan within 24 hours of flexible URS, 100% stone-free rate in Guy's 1 up to 1.5 centimeter. That's our patient. Even for more than Guy's 2 score, 100% stone-free rate. And in Guy's score 3 and 4, which are complex stones, using flexible URS, 100% stone-free rate were achieved in 93.3 patients. So this is going to be the future. And my friends, if you look at the future of URS, we are soon going to get the perfect trifecta, possibility of 0 fragment RIRS, ability to have image-proven nil residual fragment, any location, any composition, any kidney anatomy, any age group. Secondly, with minimum high-grade complication like stricture or sepsis. And it will turn out to be cost-effective because we are using disposable flexiscopes and we are minimizing the need for the ancillary procedures. And with this kind of future of FURS, what will be the future of VISAM? Future of mini PCNL, I see still there is a place for the mini PCNL, and that will be in the graveyard. Yeah, but having said that, on a serious note, see, we are all scientists, we keep evolving, and not a technique is always perfect. It's not just a technique. As we say, it's not the machine, but the man behind the machine. It is not just a technique, but the man who adopts that particular technique in that given circumstances for that given patient, that makes all the difference. Nothing to take away from mini PCNL. We are all good, because I see whenever I treat a patient, I always tell myself, whenever you treat a stone patient with whichever modality, remember one thing: you are the stone, you are the chisel, and you only are the sculptor. Remember this, and you can offer the best treatment to your patient. I really thank you from the bottom of my heart for patient listening and this kind invitation. Thank you so much, Yasir. Thank you so much, Isam.
Thank you, Joshi. It's really interesting to have these different modalities of treating the patient, treating single case different from one time to one time. The most important to keep in your hand all the techniques that you can offer to your patient, and at the end it could be shared decision with your patient, whatever more satisfactory to the patient, and always balancing between risk and benefits to this patient. I think we have 5 minutes for questions for closing this session, and I hope all the speakers are here in the room. If you have any questions to any of them. Till we get some questions, I think I have for thorium laser, I think the first to talk, do you have experience about the retropulsion effect of thorium in comparison to the holmium laser, the retropulsion effect?
So for the retropulsion per se, the thulium fiber gives the best possible, least retropulsion possible. For whatever the energy and setting that we compared with the holmium laser, it gives the least possible. And
even with the Moses technology, any study comparing both?
Yes, even with Moses technology with 120 watts, it still gives the less retropulsion compared to holmium laser, sir.
Okay. Dr. Nahas, you are here. For shockwave, you know that I think the data you said in Mansoura that still shockwave has a higher rate of or high percent of patients. But I think in many other centers, shockwave is declining. The flexible uteroscopy is taking over, mini-Berk is taking over. I think sometimes should we consider the patient preference, or it is an only a surgeon decision? Because many patients comes to us, I need the least invasive. So sometimes we can push the patient for shockwave while is not the best candidate for shockwave because he preferred that.
You have to respect the patient choice if it is within the indications and the guidelines. So when I'll ask the audience, if you are the patient and you have a stone 9 millimeter in the renal pelvis, Hounsfield unit 800, what would you choose? The one who choose shockwave, please raise your hands. So it's a majority. Because it's non-invasive. All of us are surgeons. All of us did ureteroscopy and flexible ureteroscopy and percutaneous nephrolysotome. We know the complications, but shockwave is non-invasive. Thank you.
Okay. Yeah, please.
Cystolithotherapy. I was the patient.
Yeah, this is the point. It's a valid point, Dr. Nahas, because shockwave, yes, it's non-invasive, but we facing many troubles with the patient.
On the other hand,
especially if we have non-selecting the right patient.
yes. On the other hand, the results of shockwaves are unpredictable. It's not like the endourology.
Yes, sir. See,
Yes.
the one thing which is not allowing us to use lithotripsy in a big way is it doesn't have the glamour which is there with the flexible URS. The amount of innovations happening in flexible URS and mini PCNL, we don't see that much innovations happening in lithotripsy because it is purely, in a way, it is a market-driven thing. So if you have a good machine, how many of us have good machines? How many of us have second, third generation? So that is where the whole problem is there, that we are not investing in lithotripsy as we used to be earlier. And what he rightly said is, today if I choose lithotripsy for myself, why would I choose flexible URS or mini PCNL for some other patient? Because if we have here really good lithotripter, we invest ourselves into technical intricacies. I think even today lithotripsy has definitely got.
Yeah, it's very valid point that shockwave, we feel that we have all the tool in our hand, but for flexible ureteroscopy, always you have something new in your hand, so motivating you to practice more and more. Wissam, do you have a comment?
Yeah, I'd like to comment. I think, as Dr. Nahas said, and you mentioned also, that we have to respect the patient's will. Many times, the patient comes with us with a 9 millimeter or 7 millimeter stone, and we tend to forget about the SWL, and the patient himself reminds us. We discuss, okay, we're going to take it to OR and do a flexible ureteroscopy, and the patient asks, what about shockwave lithotripsy? So we tend to forget about this, and I think it's not only about the innovations in SWL. I think because we tend to move forward with the flexible ureteroscopy, it's more fun for us that we don't apply the basic rules to succeed in SWL, like the pain management, the lack of air and the spreading of gel, the presence of a resident inside the room to locate the stone and relocate it during the procedure. That's what makes our outcomes in the SWL not as good as flexible ureteroscopy. But if we apply the rule, I think it still has a place, as Dr. Nahas said.
Okay, so one comment for Dr. Hussein and Dr. Fadel. For the best selection of the calyx, Hussein, you mentioned that you do the prone position mostly. Do you think CT in prone position is advisable? CT in prone, because you do CT usually in supine. When you have the patient in prone, the anatomy is totally different. So there are some recommendations in some centers to do CT in prone that could help you to identify the best calyx to approach. Is it right?
So you're right. Some centers, they advocate for that. However, in clinical practice, I don't see a difference, to be honest, because I work in two hospitals. One of the hospitals does that, the other hospital doesn't do that. And I didn't see clinically in my cases any difference. It might actually show up if you have a retrorenal colon, something serious to have. But if you're using ultrasound as Dr. Fadl is doing, or sometimes I'm doing as well, ultrasound-guided BCNL, I think you don't need any further information from the prone CT.
Okay. Fadl, for ultrasound, do you think it's easy to identify the real calyx, or it needs long learning curve? Especially, in fluoroscopy guided, we are looking for infundibular or non-infundibular, anterior, posterior calyx, how it take time to identify these details that we are, it's a debate always where to puncture and how to puncture guided by fluoroscopy. So how you do that in ultrasound?
So very interesting question. And in fact, the answer is very simple. With ultrasound, what you see is what you get. So the whole concept of anterior, posterior calyx simply does not apply. Because I do mainly supine PCNL. 90% of my perks are supine. And I do prone. And the learning curve is not necessarily that different. But the reality is that with ultrasound PCNL, you need to prove two concepts. One, that you can see the calyx properly. So having a good hydronephrosis is key, whether you fill in a retrograde fashion with saline or you can give some Lasix at the beginning of the case. This will make your life much, much easier. Two, you need to prove that this calyx actually connects with the stone. So if you simply fan with your ultrasound, you can see the collecting system and you can see it very, very well. And if you can prove that you can get to the stone from any calyx that you see, then that's a good calyx to puncture. And the whole concept of anterior, posterior simply does not apply, which is why I think it makes it significantly easier.
Okay. Just a comment here. For the anterior and posterior calyx, I think it doesn't really matter, especially if you're doing supine position. If you're doing prone position, then the straightest axis is probably a posterior, right? I think what makes a difference is how much of the renal parenchyma you're actually traversing with your needle. If you're going tangential and you're going in a different, weird angles through the renal parenchyma and very deep in the renal parenchyma, then the probability of hitting arteries and, vessels is much more. But if you have an anterior calyx that comes like straight to your eye and you can achieve the axis with the smallest renal parenchyma traversed through your needle, I think that's the best calyx to be punctured, whether it's anterior or posterior. But my preference for posterior because I'm doing prone position still.
Okay. We have one question here, please.
It's a comment for Dr. Fadel about the learning curve. In our hospital, we have a program how we teach our residents. In the second years, we allow the resident how use the ultrasound and do the ultrasound for all the patients, the inpatient and the outpatients. In the second years, the third years, we allow them to do a nephrostomy by themselves. In the fourth year, start to do ultrasound, pure ultrasound, PNL. So in the fourth and fifth year, we become excellent to do the PNL. Also, another trick in ultrasound, and the magic of the ultrasound, is the Doppler. The Doppler ultrasound is very beneficial to know the vascularity. And also you can use the ultrasound safely in a pregnant patient. It is more superior than fluoroscope. And also we have, we made new techniques in our hospitals. We called it hydrodissection ultrasound guided PNL. And also another technique, we called it optical hydrodissection ultrasound guided PNL. So the hydrodissection will become safe to dissect the colon away from the lower pool, and can you enter any calyx you want. And the optical hydrodissection, we use both. We dissect and see immediately because there is a lens inside the needle. And there is many techniques you can use the ultrasound. One of them use what we call it segmental hydrocalyx. When put a tube in the lower calyx of the kidney, so there is the kidney will be shrinkage because there is no pressure. So we put a Foley catheter and make a segmental hydrocalyx to enter, if you want to enter another from another calyx, like upper or another mid calyx.
So thank you, Dr. Mohammed. It's very valid comments, but please, because we are having shortage of time, so thank you for these comments, and we can discuss during the coffee.
I just want to make one quick comment. Thank you for your comment. I think to support what you're saying, establishing an ultrasound curriculum in your training center is extremely important if you have residents, and to start with them starting PGY1, and that's what we did at McGill University. So yes, I agree with you. If you start early, then by the time you're, you're finishing, you're actually quite competent. I agree.
Okay, thank you very much.
I'd like to thank all our speakers. It was really a very interesting session covering very interesting topics. That's the bread and butter for everyone working in urology, urolithiasis. Thank you.